Hello and welcome to the presentation No Level is Safe, a review of lead poisoning and prevention in Washington State. Brought to you by the Region 10 Northwest Pediatric Environmental Health Specialty Unit and the Washington Department of Health CDC Childhood Lead Poisoning Prevention Program. My name is Mary Kate Carden. I'm a certified pediatric primary care nurse practitioner and the co-director of the Northwest Pediatric Environmental Health Specialty Unit at the University of Washington Department of Environmental and Occupational Health Sciences. Disclaimers. This presentation was funded by the Washington State Department of Health, and the work of the PACU program is funded and supported by the Centers for Disease Control, Agency for Toxic Substances and Disease Registry, and the U.S. Environmental Protection Agency. The contents are those of the authors and do not necessarily represent the official views nor an endorsement by CDC, ATSDR, EPA, or the U.S. government. Use of trade names that may be mentioned is for identification only and does not imply endorsement by the CDC, ATSDR, or EPA. For those of you who are unfamiliar with the Pediatric Environmental Health Specialty Unit program, or the PACU program, I'd like to spend a little bit of time talking about who we are and what we do. So the PACU program is sponsored and funded by the CDC, ATSDR, as well as the EPA. We are divided into 10 federal regions, and each region is based at an academic medical center. The Northwest PACU, or Region 10 PACU, covers Alaska, Idaho, Oregon, and Washington, and is based at the University of Washington in Seattle. The PACU program is comprised of specialists in multiple fields, including medicine, nursing, public health, exposure science, and more. And in a nutshell, what our program does is offer free consultation, outreach, and education to a variety of different audiences, including clinicians and healthcare professionals, public health departments, communities, as well as individual families. At the conclusion of this presentation, the participant will be able to explain the significance of identifying lead-exposed children, list 2 potential risk factors for lead exposure, describe the importance of timely intervention and follow-up care for children exposed to lead, outline the difference between state and federal lead testing recommendations and requirements, including Washington State reporting obligations, list 3 resources available for childhood lead poisoning prevention, and describe the importance of interprofessional collaboration in addressing lead exposure in children. To start us off, we'll do a little bit of background about what lead is, some trends in lead exposure in the United States over the past several decades, as well as discussing the CDC blood lead reference value. Beginning with what we know about lead and children's health. There is no safe level of lead, and the developing brain is particularly sensitive to lead exposure. Federal regulations mandate that all children covered by Medicaid insurance get a blood lead test at both 12 and 24 months of age. There is a need to improve lead screening and lead testing rates in Washington, and healthcare providers play a critical role in both primary and secondary prevention of lead exposure in kids. Lead is a naturally occurring toxic metal that's found in the Earth's crust. There's no biological role for lead or level at which it's necessary or beneficial to the body, so there's no safe level of exposure. Through various mechanisms, and depending on the degree of exposure, lead can cause damage to many body systems. But in children, particularly in the United States, we worry most about the effects of low-level lead exposure, which is what we're seeing most often in the United States, on the developing brain, as lead acts as a potent neurotoxicant. Many of the neurological and behavioral health effects of lead exposure are believed to be irreversible. Much of our exposure comes from contamination due to human activity, and widespread use has resulted in extensive environmental contamination, human exposure, and a significant public health issue still talking about today. Taking a look back at trends in lead exposure in the United States over the past several decades, as you can see in this infographic on the right-hand side, thanks to several lead poisoning prevention policies, such as the removal of lead from gasoline and paint for residential use, mean blood lead levels have declined significantly. This is a great demonstration of primary prevention, or removing lead from the environments of children before exposure occurs. However, the work isn't done. Since lead persists in the environment, historical sources still impact children today, and novel sources of exposure have been discovered. Today, in this presentation, we'll be focusing on secondary prevention, or identifying lead-exposed children through screening and testing, and then taking action to prevent ongoing exposure. The CDC has adapted what is called the blood lead reference value over the years to reflect this decline. Currently, the blood lead reference value is set at 3.5 micrograms per deciliter. So I mentioned the CDC's blood lead reference value. Let's talk about what it is and what it's not. The blood lead reference value is not a health-based value or toxicity threshold, hence why we say that no level is safe. Rather, it's based on national survey data of blood lead values amongst U.S. children. This dataset is called NHANES. This is a population-based survey to assess the health and nutritional status of adults and kids in the United States and determine the prevalence of major diseases and risk factors for diseases. Every 4 years, the CDC reanalyzes blood lead data from the most recent 2 NHANES cycles to determine whether the blood lead reference value should be updated. The reference value is based on the 97.5th percentile of blood lead values amongst U.S. children ages 1 to 5 years old. So, children with blood lead levels at or above 3.5 micrograms per deciliter represent those at the top 2.5% with the highest blood lead levels. So what the reference value is a tool to identify children with levels that are higher than most, so that public health action and medical intervention can be initiated. Now, we'll discuss lead exposure sources in children's environments. Thinking now about lead exposure sources, lead-based paint is the most common exposure source in many situations, and housing age is still the best indicator of lead exposure risk that we have available. We're particularly thinking about homes built before 1978, and that's because that was the year that lead-based paint was banned for residential use. The risk of exposure increases with the age of the home, and also increases if paint is deteriorating and can lead to chipping and dust and debris on the floor that kids are coming into contact with, and can also increase if home renovations are conducted, particularly not using safe practices. A family's drinking water is another exposure source to consider, as older homes may have old lead-containing plumbing, pipes, and faucets. This is a particularly important source to consider in formula-fed infants, in whom parents are using tap water to mix infant formula. Public water systems regularly test for lead as well as other drinking water contaminants, but it's important to note that homes that their primary source of water is coming from a private well are responsible for testing their own water regularly for lead and other drinking water contaminants. So this is something to consider when you're speaking with the family about their drinking water source. Lead-contaminated soil is another exposure source to consider. Lead can contaminate the soil due to deteriorating paint around older buildings or perhaps old playground equipment. Lead can also settle in the soil from emissions from nearby roadways, from past leaded gasoline use, as well as airports from past and current leaded gasoline use. In the top left-hand image on this screen, you can see a small piston engine aircraft and avgas, which is leaded gasoline that's still used today. Leaded gasoline is also still used and allowable for certain off-road vehicles. Emissions can also settle in the soil near waste sites and via industrial sources, for example, smelters. Lead can also contaminate soil on former orchard land, where past use of lead arsenate insecticides caused lead contamination in the soil. Lead can also be found in more unexpected places, in consumer products and imported products. Specific examples of categories of these types of products where lead has been found in the past as a contaminant or an ingredient are in toys, particularly those that are old and antique and perhaps lead painted, or those that are imported where there are less strict regulations on lead-based paint use on children's items. Certain jewelry can also potentially be lead contaminated, particularly the more costume and inexpensive children's toy jewelry. Dishware and cookware and pottery are also potential exposure sources, again, particularly those that are antique and perhaps lead painted or imported. You can see in the right-hand graphic on the top, that is a aluminum cookpot, and imported aluminum cookpots were a novel source of exposure and the main source of exposure in a cluster of childhood lead poisoning cases in the Afghan community in King County a number of years ago. Certain food and drink are potential lead exposure sources. Lead can be present in food from the environment where foods are grown, raised, or processed. And the FDA is responsible for monitoring and regulating levels of lead in foods. Some examples are what you may have seen in the news. A number of years ago, lead contamination in applesauce pouches due to the cinnamon. Also imported candies and spices, such as turmeric and cinnamon, again, as I mentioned before. Unfortunately, although lead can contaminate spices during many points in the production process, Sometimes lead is intentionally added to spices to increase the weight and the worth. Traditional medicines or remedies or supplements are also another category of potential lead exposure sources, which is again broad. We do have a fact sheet about this on our Northwest PACU website that addresses specific medicines that are used more commonly in certain communities. And then cosmetics is another potential category, specifically here thinking about what's pictured on the bottom right-hand side of the screen, which is kohl or kajal. This is an ancient eye cosmetic that's sometimes used to treat eye injuries and infections. It's been banned in the US for sale, but still used by many communities and brought into the United States. Thinking about jobs and hobbies where adults in the home may be exposed to lead and may track it home in their vehicles or inside on their clothes and shoes, and children may be exposed that way. These are not comprehensive lists, but just some examples of jobs and hobbies where people may be exposed, including construction, mining, of course, lead smelting and refining, waste incineration, battery repair, casting or soldering, mixing or applying glazes and pottery work, firearms, shooting, target practice, or hunting using leaded ammunition, are just some examples. Moving now to thinking about the health impacts of childhood lead exposure. Young children are particularly vulnerable to lead exposure, as well as many other environmental exposures. This is due to factors such as unique activity patterns and behaviors, physiological differences, windows of susceptibility during early life stages, a dependence upon adults to ensure a safe environment, as well as more years of future life, and the potential for greater cumulative lifetime exposure, as well as latent health effects. Thinking about unique activity patterns and behaviors that place children at greater risk of lead exposure, children consume more dust, dirt, and non-food items through normal oral exploratory behavior. Children are spending more time near the ground and outdoors, as we hope, engaging in curious behavior. Children have undeveloped and inexperienced decision-making capacity, little to no hazard avoidance, and again, reliance upon adults for protection. And there are also unique routes and pathways of exposure, such as transplacental exposure and exposure via human milk, that we'll talk about a little more on the next slide. Thinking about lead exposure pathways, ingestion is a primary route of exposure for kids. Many of these exposure sources we discussed earlier, but to touch a little bit more on human milk exposure, maternal blood and milk lead levels are correlated, but the efficiency of lead transfer from blood to milk varies at lower maternal lead levels. Generally, the guidance is that the benefits of breastfeeding outweigh the risks when maternal blood lead levels are under 40 micrograms per deciliter. However, there are nuances to this guidance, and testing intervals and recommendations differ from typical guidelines. And so the Northwest PACU has a great fact sheet on lead medical management in pregnant individuals and breastfeeding infants that aligns with ACOG's recommendations. And so I would recommend checking that out for more information. Inhalational exposure is also another potential exposure pathway to things like dust, secondhand smoke. Traditional cigarettes contain trace amounts of heavy metals, including lead, general air pollution, as well as leaded gasoline. And then thinking about transplacental exposure, lead readily crosses the placenta by passive diffusion. Cord blood lead levels are strongly correlated to maternal blood lead levels. with cord levels being on average 0.8 times that of maternal blood lead levels. And interestingly, maternal blood lead levels can increase in the third trimester and through the postpartum period without changes in environmental lead exposure, and this is due to increased mobilization of lead from bone stores for women who have bone lead stores. Thinking more about risk factors for childhood lead exposure, young children, particularly those under the age of 6, are at greatest risk. This is partly due to age-appropriate behavior, such as crawling and mouthing behaviors, but also because of differences in GI absorption compared to adults. Kids absorb up to 100% of ingested lead on an empty stomach, whereas adults only absorb 60 to 80% of ingested lead on an empty stomach. Specific nutrient deficiencies that are common in young childhood, such as iron deficiency, is associated with a 4 to 5-fold increase in lead exposure, and this is due to increased lead absorption. Young children also have an incomplete blood-brain barrier, rendering them more vulnerable to lead's neurotoxic effects. Poverty is another risk factor, defined as household income under 130% of the federal poverty level, living in older and or substandard housing due to lead paint exposure risk, living in a smoking household, again, traditional cigarettes have trace amounts of heavy metals, recently traveling to, immigrating from, or being adopted from countries where lead poisoning is more prevalent due to environmental lead contamination, living near a Superfund site where lead contamination is present, having a parent or adult in the household who engages in a job or hobby that may involve lead exposure, having poor nutrition, certain developmental disabilities, ingesting human milk from a person with an elevated lead level, having a sibling or frequent playmate with an elevated lead level, and being a child in foster care. Key pediatric health concerns. This graphic shows the key concerns in relation to blood lead levels. Very high level of exposure, represented by blood lead levels greater than or equal to 45 micrograms per deciliter, are relatively rare in the United States. Most lead toxicity in U.S. children is subclinical and identified only with a blood test that demonstrates elevated exposure. As blood lead levels rise, children may experience nonspecific symptoms like headache, abdominal pain, appetite loss, and constipation, and very high exposure can result in frank anemia and CNS involvement with symptoms like clumsiness, agitation, vomiting, convulsions that can progress at extremely high blood lead levels to encephalopathy. The data on this slide comes from an evidence review of low-level lead exposure effects that was done by the National Toxicology Program in 2012. Their findings included sufficient evidence of an association between lead exposure and health effects at these blood lead levels. So for blood lead levels under 5 micrograms per deciliter, found sufficient evidence of an association between decreased academic achievement, lower IQ scores, attention-related behavior problems such as ADHD, antisocial behaviors, which they use as an umbrella term to describe conduct disorder, delinquency, and criminal behaviors, which of course can result from a variety of risk factors, but there is substantial evidence that lead toxicity in childhood is one of the major risk factors in their development, as well as in association with maternal blood lead levels under 5 micrograms per deciliter found reduced fetal growth. For levels under 10 micrograms per deciliter, they found sufficient evidence of an association between delayed sexual maturation and puberty onset in both males and females, decreased postnatal growth, as well as decreased auditory acuity. There was also limited evidence of an association between maternal blood lead levels under 10, as well as the incidence of spontaneous abortion and premature birth. Studies have shown that children with a blood lead level greater than or equal to 5 micrograms per deciliter will, on average, experience a lead-associated IQ deficit of around 6 points. So what is the significance of these small individual IQ reductions? You can see in these graphics that the population impact is actually quite substantial, demonstrated by a left shift in the distribution of intellectual abilities in lead-exposed U.S. children in that top right-hand infographic labeled B, compared to non-lead-exposed children in the top left infographic labeled A. Despite the dramatic reductions in blood lead levels over the past few decades, as we discussed earlier, lead toxicity still accounts for an estimated total loss of 23 million IQ points, and this was among a 6-year cohort of contemporary U.S. children. Interestingly, lead-associated IQ decrements are proportionately greater at the lower blood lead concentrations. To me, this data demonstrates the long-term cost to society and emphasizes the societal benefits of mitigation. And now we'll transition into talking about lead screening and testing, recommendations and requirements, both federal and specific to Washington State. I always like to begin this portion of the presentation by defining what I mean when I'm saying screening and testing in the context of lead exposure and lead poisoning. When I talk about screening, I'm talking about using questions or using a questionnaire to evaluate the risk of lead exposure. And when I'm discussing testing, I'm talking about actually measuring lead in the blood, whether that be via a capillary or a venous sample. So again, for screening, this is assessing lead exposure risk via a questionnaire at well child checks 6 months through 6 years of age. And as I mentioned earlier, this is a Bright Futures AAP recommendation, and you can see the arrow pointing to lead screening on the periodicity schedule here. The Washington State Department of Health has developed this screening tool, the recommendations for childhood blood lead testing in Washington, for providers to use to help guide decision-making on performing a blood lead test. This was recently updated in 2026 and can be found on the Washington DOH lead webpage. Another important tool in Washington State that can help evaluate risk of lead exposure as well as target outreach in communities in Washington is the Washington Tracking Network's Lead Risk Index map. In this map, lead risk is based on data on poverty and housing age and is available for all of Washington State. The tool also has some state and county level data on blood lead testing rates, as well as rates of elevated blood lead levels amongst children in those counties, and then also has layers for mapping certain lead exposure sources that are specific to Washington, including smelters, former orchard land, as well as airport proximity. So who gets a blood lead test in Washington State? For children who are covered by Medicaid insurance, the federal mandate applies. The federal mandate is for all children at ages 12 and 24 months to receive a blood lead test, regardless of other lead exposure risk factors. And if a child has not had a blood lead test done by the age of 6 years old and they're covered by Medicaid insurance, then they should be receiving at least one blood lead test. If a child is not covered by Medicaid insurance, providers should ask questions to evaluate potential lead exposure risks in the child environment and perform a blood lead test if risk factors are identified through this screening. There are also specific guidance from the CDC on blood lead testing recommendations for newly arrived immigrant and refugee children, which I'll go over in more detail on the next slide. And because I'm sure that many of you as providers are seeing newly arrived immigrant and refugee children, I wanted to include the CDC recommendations for lead testing in this population, which include obtaining an initial blood lead test within 90 days of arrival. And this is for infants, children, and adolescents 16 years of age and younger, as well as pregnant and lactating individuals, and then provides recommendations for follow-up blood lead testing 3 to 6 months after that initial test. And this testing recommendations depends on the child's age, as well as what their initial blood lead level was, in addition to current environmental lead exposure risk. At the PACU, we get many questions about whether capillary or venous samples should be used for blood lead testing, and there are pros and cons to both method, and it's really what you have available to you and what works best with your clinic workflow. For the capillary or point of care lead testing, of course it's easier to collect. It would be just a finger stick or a heel poke, and the results are quickly available. And this can be done in a clinic, so families don't have to travel to an outside lab. The cons is that capillary samples are actually more easily contaminated during the collection process, so there is a higher rate of false positives and the need to confirm with a venous sample if the capillary result is elevated. Venous samples are the gold standard. They're more accurate with less chance of contamination in the collection process. However, the cons are that highly trained staff, such as phlebotomists or nursing staff, are needed, and it may be a barrier for families who are not able to travel to the lab, or it may be difficult for them to get to an outside lab. And of course, the results are not as immediately available to you. So let's take a look at childhood lead testing data in Washington. This graph shows the number and percent of kids 0 to 5 years of age tested for lead in Washington state between 2013 and 2024. You can see that this rate is increasing. Historically, child blood lead testing rates in Washington have been low. For example, in 2018, in Washington, around 4% of kids 6 years of age and under received a lead test, compared to the national average at the time of around 18%. It is important to acknowledge that all states take a different approach to testing, ranging from universal testing at ages 12 and 24 months, regardless of insurance or individual risk. In some states, it's even required for school entry. And then other states take a risk-based testing approach, like in Washington, where outside of the federal mandate for testing kids with Medicaid insurance, we're asking questions and performing screening, and only performing testing on children without Medicaid insurance if they have risk factors for exposure, or based on clinical decision-making in conversation with the parents. It's also important to acknowledge that lead testing rates did decline during the pandemic, as did so many critical primary care services. And in 2021, there were recalls of point-of-care lead testing kits, which also impacted the testing rates. So we're still recovering from some of these setbacks in the previous few years, but also making improvements and still room to continue growing. Taking a look now at lead testing for children in Washington enrolled in Medicaid, the Washington State Auditor's Office conducted an audit of lead testing for children enrolled in Medicaid insurance in Washington State published this in December of 2023. Their goal was to better understand how Washington was doing meeting these federal lead testing requirements, to identify areas for improvement, and make recommendations for state agencies on how to meet these requirements and better serve Washington children. So what they found was that more than 240,000 of Washington's 2.3 million Medicaid enrollees are under 6 years of age, so in this peak exposure age range for lead. Compared to all other states, Washington has been in the bottom 20th percentile for testing Medicaid-enrolled children for the last several years. Only around 26% were tested or received a blood lead test at least once by 6 years of age, which is again that minimum safety net standard for this federal mandate. And only around 3% were tested at both 12 and 24 months, which is that full mandate and requirement. So again, just another set of information and data looking into how we can improve these testing rates, and I encourage anyone who's interested to go and take a look at that audit and take a look at some of the recommendations that were made to, again, better meet these requirements and better serve children in Washington.
And now we'll discuss the medical management as well as the follow-up care of lead-exposed children. On this page, I've highlighted the National PACU document, Recommendations on Management of Childhood Lead Exposure. This is just one page of the document, and as you go through it, it breaks down actions that you'll take based on what the blood lead level is. Regardless of what that initial elevated blood lead level is, management is always going to involve an environmental exposure history so that we can accurately identify and remove or mitigate the lead exposure sources in the child's environment. Medical management is also always going to include monitoring repeat blood lead levels to ensure that they are trending downwards, signifying that our interventions are working. And in the next few slides, I'll go over recommended follow-up testing timetables. Management will also include nutritional status evaluation and counseling, specifically thinking about iron and calcium. Sufficiency of both is important for reducing lead absorption. Vitamin C, of course, sufficiency of which is important for iron absorption. And vitamin D, as lead poisoning can inhibit processes by which vitamin D transforms into the active form in the body. Management will also include neurodevelopmental screening and considering referring to enrichment services, such as a Birth to 3 program, to promote neurocognitive development in lead-exposed children. Consulting a specialist, such as the Poison Control Center or the PACU program, particularly for levels that are above 20 micrograms per deciliter, higher levels that we don't typically see as often in the United States. But really, the PACU program is available to you and to help guide for blood lead levels at any range. At higher levels, you'll likely need additional labs and/or imaging. Let's say in the environmental exposure history, you're concerned that the child has ingested a lead-contaminated foreign body, and you may need an abdominal X-ray. And then chelation therapy is reserved for very high blood lead levels, 45 micrograms per deciliter or higher, and this is typically done in the inpatient hospital setting and in consultation with a medical toxicologist.
So let's say that you've gotten an initial capillary blood lead level that is elevated. This is the recommended schedule for obtaining a confirmatory venous sample. And of course, the higher the initial capillary blood lead level, the more quickly you're going to get that confirmatory venous test. And once you've confirmed that a child has an elevated blood lead level on a venous test, this is the recommended schedule for follow-up blood lead testing. And again, the higher that the venous blood lead level is, the more frequently that you're going to be getting follow-up testing as you're working to identify the exposure source and mitigate that exposure. To review the Washington State lead reporting requirements, in Washington, all blood lead levels are reported to the State Department of Health. Laboratories are required to report elevated lead levels within 2 business days, and all other blood lead levels within 1 month. It's important to note that if a clinic uses a point-of-care lead testing machine, that clinic is considered the laboratory, and thus they are the responsible reporting party. These results are then uploaded to state database, and local health departments are notified about any lead levels that are elevated greater than or equal to 3.5 micrograms per deciliter so that they can respond. Information on this reporting process can be found on the Washington Department of Health lead webpage. Thinking about the important role that public health plays in management of children that have been exposed to lead, each county has jurisdiction over the elevated lead level response for its residents. The local health response may include a telephone interview, a home assessment, as well as other services as needed and based on their capacity. The State Department of Health may provide technical assistance and can conduct response to elevated lead level cases at the local health jurisdiction's request. The goals of the public health response are to help identify the likely source or sources of lead exposure, provide education on reducing exposure, encourage follow-up blood lead testing with the child's PCP, and connect families to appropriate resources. It can be difficult for families to come to terms with the fact that their child has been exposed to lead, when in many cases the child does not often look or act sick. So I often talk about contextualizing this for the families and explaining that lead exposure may not be reversible. However, it's not a guarantee that health effects will occur, and there are ways that we can support child development to help, in a sense, offset exposure. And this is done by emphasizing and focusing on nurturing safe and stable influences and environments, and discussing the importance of all of the things that you're already talking with families about at well child checks, and referring to early intervention services when necessary. And lastly, I'd like to go over a few simple anticipatory guidance points that you can provide to families when thinking about preventing and mitigating lead exposure. First, as it is the most common source, as I mentioned, in many situations, thinking about some simple steps that families can take to mitigate or prevent exposure to lead from paint. Keeping kids away from peeling or chipping paint, as well as keeping them away from home repairs that may disturb lead-based paint. Frequently washing hands, toys, pacifiers, anything that's going in the child's mouth that may be lead contaminated if there's lead-based paint in the home and there may be dust and debris on the floors. Cleaning floors, windowsills, dusty places often with wet mops and wet cloths. Windowsills and door frames particularly are areas of high friction, so if there is lead-based paint in these areas, they're higher risk for degrading and creating lead-based dust that's on the floors that the child could potentially be exposed to. And then using safe methods when doing home repairs that may disturb paint. And the EPA has a repertoire on their website of contractors that are lead safe certified if families are interested. And then for renters, reporting peeling or chipping paint to the landlord as soon as possible. And if families are experiencing issues when reporting to landlords, referring families to tenants' rights organizations.
Thinking about exposure sources beyond paint, counseling families on avoiding using traditional medicines, remedies, cosmetics from other countries, and searching for safer alternatives, not letting kids play in bare soil in areas that have known or potential lead contamination, keeping kids away from work clothes and tools of household members who engage in work or hobbies that may expose them to lead, and washing work clothes separately from other laundry, and removing work clothes and shoes before entering your home. The Consumer Product Safety Commission is a helpful website where families or providers can look up recalls for products based on product type or hazard of concern, including lead.
Thinking about drinking water as an exposure source, simple steps like running the tap for several minutes after water's been sitting in the pipes. Using cold water for drinking, cooking, and making baby formula. Cleaning screens and aerators and faucets to remove any captured lead particles. Using lead-free piping and materials for plumbing when building or remodeling. And then considering using a water filter, checking whether it reduces lead because not all filters are meant to. And the bottom right-hand photo is of the NSF, which is a third party that certifies filtration devices, including ones that specifically filter lead. And they have an inventory on their website ranging from cheaper point-of-use options to whole house filtration systems.
And finally, some resources that are available to you, both national as well as Washington state specific. Starting with PACU-led resources, on the left-hand side of the screen, I have a screenshot of our Northwest PACU website resources page, which contains a lot of really helpful fact sheets and videos and more resources about lead exposure, many of which are specific to children living in Washington state. And on the right-hand side of the screen is the National PACU webpage for lead for health professionals, which includes the medical management document that I mentioned earlier in the presentation. And here are some Washington DOH lead resources. Their main lead webpage is that hyperlink at the first bullet point. And then they also have a lead publications page that has links to resources for both families and healthcare providers, such as the lead test card seen on the right-hand side of the screen. They also have provider and family quick guides about lead exposure in kids. Some of these resources are available in print and can be ordered at no cost to providers from the Washington Department of Health via their website, and many of these resources are available in multiple languages.
Thank you for your attention to this presentation and for helping to prevent childhood lead exposure in Washington State.